All right, well, I think we'll go ahead and get started. Thank you so much for joining us today. My name is Robbie Franceschini. I'm Director of Policy with Blue Path Health and also help lead policy efforts with Connecting for Better Health, a California-based coalition dedicated to advancing data sharing policy in the state. We're really excited to be here today to discuss legal considerations related to consent to share. Before we jump into content, we just love to mention a couple housekeeping items. Everyone here who's an attendee will be on mute today and with video off. Please, if you have any questions for any of our speakers today, please put those in the Q&A. That way we'll make sure to get to them when we get to the question and answer portion of the session. Please feel free to use the chat to share any insights, introduce yourself. We welcome folks to use the chat for that functionality. And we'll also be sharing links through the chat as well. This webinar will be recorded. We'll make sure to share it with all attendees via email and through social channels after today's event. And we'd also like to note that closed captioning is available at the bottom of your toolbar. We do have a live closed captioner today if you would like to utilize that. We also will be sharing links in the chat, in particular related to the state health information guidance and the California data sharing authorization guidance, key state materials that we think are super valuable to stakeholders working on data sharing efforts and really interested in learning more about consent to share. So to provide some context to today's event, we'd really like to thank the California Healthcare Foundation for sponsoring this webinar series. This is the second in a four-part series focused on consent to share. Our first event just held last month really focused on the Ask Me pilots, which were funded by our state Medi-Cal agency to test out a single consent to share form utilized by plans and provider partners working on CalAIM in several counties in the state. Our next two webinars will be focused on standards related to consent to share, as well as funding and technology and how we really make this work come to life with consent management. We also, too, hot off the presses, are excited to see California Healthcare Foundation publish a white paper that really is the crux of this work and really spurred this four-part webinar series. So please check out the chat for the link to that paper. We're so excited to see it come out. You'll find in the paper that several recommendations really came out of that work that included interviews and a review of the literature out there as well. These included devising a communications and education effort to align legal guidance and laws surrounding consent and privacy laws. That'll be the focus of today's session. Other recommendations included bolstering efforts to develop consent to share technology, standards, and policy. Additionally, around developing a standard consent form based on the Ask Me pilot findings. And I think, certainly consent forms may come up in conversation today. And then lastly, just around establishment of statewide consent management programs, depending on what level those take shape in the community or within the state, with this strategy for digital identities and other policy initiatives to really improve data sharing in California. So again, we're really thankful to CHCF for sponsoring this work. To provide a little bit of context to today's session, one thing we really heard in our interviews that really helped shape the white paper is that consent to share is really critical in the process of sharing data. Often it's seen as a barrier, whether because of real or perceived legal issues that stakeholders and organizations encounter. But nonetheless, we recognize that it's a significant component of data sharing in the context specifically of sharing across sectors in CalAIM as well. California is super lucky to have resources like the State Health Information Guidance that the California Health and Human Services Agency has published that provides summaries of federal and state privacy laws that apply to data sharing in California, including an analysis of laws around criminal justice, health, housing, nutrition programs as well. We have a CalAIM data sharing authorization guidance that is really geared towards managed care plans, community-based organizations, justice as well, organizations that are providing services in the Medi-Cal program as part of CalAIM in its various programs and initiatives. However, many organizations continue to hesitate to share data, may see some conflicts between those guidance documents that raise questions or make them think that, they maybe shouldn't be sharing information with other organizations. And I think today what we're really hoping to do is be able to uncover some of those issues and also solutions to them, really to provide further insights to how our state agency leaders can really be able to provide better guidance to stakeholders. And additionally, I think not just for agency leaders, but other stakeholders, really think about what policy changes might be needed to be able to help align, harmonize, update privacy laws that affect consent to share data. We'll also touch as well on, the important question that arises in this conversation, really around how do we strike that right balance between, ensuring autonomy for individuals and caregivers when it comes to sharing of information, and making sure that data gets shared with the right providers and plans and organizations at the right time as well. So with that context, I would love to introduce our speakers and invite them to come off mute and onto video. Our guests today include Crystal Eubanks. She's the Vice President of Care Transformation at the Purchaser Business Group on Health, where she leads the California Quality Collaborative in its ambulatory care improvement programs. Thanks so much for joining today, Crystal. We also have Mohit Ghosh, who's the Senior Director of Anthem Government Relations here in California. He brings over 20 years of public affairs, policy, and operations experience in the private sector and in government programs. Excited to have you here, Mohit. We also have here Shelley Brown. She provides privacy and legal counsel for 211 San Diego, as well as Serving Communities Health Information Organization. And if I'm not mistaken, also served as an advisor on the development of the SHIG as well. So thanks so much, Shelley, for joining. And lastly, we also have Devin McGraw. She's the lead for data stewardship and data sharing at Invitae, which is a clinical genetic testing company. She was previously the Deputy Director for Health Information Privacy at the Health and Human Services Office for Civil Rights. Many of you will be familiar with them as OCR, and as the overseer of HIPAA. And she also previously led a think tank for health information privacy too. So thanks so much for joining, Devin. And to really kick off the conversation today, I'd love to have all of our panelists provide a little bit more context to their work and how consent and the subject of legal guidance and harmonization of laws affects you in your work. So Mohit, I'd love to turn to you first on this question.
Thank you for that. And thank you for the context, Robbie. It's a pleasure to be here on behalf of Anthem and Elevance Health, our parent company, but Anthem Blue Cross in California. As you know, we've been in the state for many, many decades and have literally worked on the transformation and through the transformation of the healthcare system, trying to integrate it more, trying to get better data to improve quality over time. And this is commercial, this is Medi-Cal, this is Medicare. So when we look at data and the consent ideas around it, we want people to feel secure in how they share their data with us, what permissions they give us to use their data. And that's from a consumer standpoint, very important to have that consumer buy-in. But equally importantly, on the flip side of that, we need institutions to understand the rules and try to bring those rules together in a way that allows us to deliver the best pattern of care coordination, just as one example, or being able to report on quality as another example. So being able to have access to data with the permission of the owner of that data, and that can get into legal issues as well in California. Who owns the data when it's generated? Is it the treating physician or is it the patient themselves? And on the federal level, we want to make sure that the laws on the federal level and the state level are very much aligned so that we can make sure that we're following everything we need to stay compliant. So very important issue for us and, happy to be a part of the discussion.
Thanks so much, Mohit. And it's great to have a health plan here today, because I think often folks wonder why health plans might care about consent to share. So really appreciate that context. Shelley, I'd love to turn to you next.
Well, thank you, Robbie. And thanks to BluePath Health for having me here today. I really appreciate that. Consent to share really is kind of a new concept in terms of HIEs. So we're now getting the opportunity under the state's data exchange framework to bring in social services agencies and delve into the challenge of sharing health information across sectors. So that is in the baby stages of data sharing from the HIE side. But then on the 211 side, on the CIE side, we've been doing this for a while. And so we have some lessons learned and some great experience we'd like to share with the greater community. Consent, of course, is at the heart of that. It has been at the heart of that. So, consent is very important in getting buy-in from the community on what consent looks like and when we can share information and for what purposes is very important, as well as, to Mohit's point, educating consumers, patients. Why are we sharing data? How is it going to be secured? Who has access? All of those things are, right now coming up in the conversation. And again, it's just great to see that happening.
Excellent. Thank you so much. And Devin, would love to turn to you.
Yeah, I mean, consent is something that I feel like I've been thinking about both from a sort of practical standpoint of kind of as a law implementer, as a healthcare provider in California, but also in the context of, when is it important to provide consent and when do you not provide consent? And I think a lot of times people think about consent as being an important component of protecting an individual's privacy and giving them autonomy. And I wouldn't dispute that at all. But there's also all kinds of research about just how much that falls down on the job, even when you try to do a really good job of it, because people don't tend to read what you put in front of them, no matter how short you make it. If you make it short, people worry that it's not sufficiently informed. So you make it long, and then people don't really read it and they check the box because they want what they want and they want their health data shared, or they are in a healthcare encounter and they're, it's part of a number of things that they're being asked to do when they're sick. So we've also seen, nationally, that when we do require consent for the exchange of health information, even for just treating patients, that data tends not to move very well. And it's not necessarily because patients don't consent. There's an operational challenge to reaching people and making sure that you have an opportunity to put something in front of them and to allow them to share. So, but having said all of that, we do have some laws that do require that consent be obtained before certain types of data can be shared. And we also don't ever want to surprise people about and surprise them in a way that doesn't delight them, right? Surprise them in a way that makes them feel not great about the healthcare system or nervous about their data if suddenly they realize that certain data about them that they consider to be very sensitive, whether covered by a law or not, is going to places that they didn't realize. So I think there are a number of challenges that we face in terms of making sure that we can exchange all the different types of data that can be useful to a person's care, but in a way that they trust. And consent obviously has to be a part of that. So figuring out a way to navigate that is obviously critically important.
Mm-hmm. Yeah, and I love that you mentioned trust as well as the fact that we, I think face the reality too, we have a lot of these laws, and especially in California, right? We don't have the ability to waive federal laws, and many of those are, they're very much still in place. And appreciate to the kind of operational lens that I think both you and Shelley can bring to the conversation too, when it comes to translating law past, a data sharing agreement into, workflow and operations. And, I'm excited to have you here too, Crystal, to, I think, shed some light on that as well, from your perspective at CQC as well.
Yeah, I just want to build on that. I mean, the operational pieces, and I think consent forms can be used as engagement tools, right? And I feel like we come into this, it's about engaging patients in their care. And when patients are engaged, they are empowered and they're driving things forward with a care team that supports them. And so we miss such an opportunity to begin that engagement process, which I think often happens after the consent, could actually happen with the consent, because that is a dialogue with the care team, right? And that shared decision making there. So in our role at California Quality Collaborative, our kind of mission is to support care teams and delivery orgs to improve ambulatory care and improve health outcomes. And data sharing is critical to that happening in both amongst providers, amongst organizations. And I can't tell you how often that we are working on the ground with practices on improvement projects, and that consent comes up as a barrier to improvement. And not that they don't want to improve and not fully engaged as care teams, but like that is a step that is so challenging. And really it's because of this lack of clarity that cascades through the system, and it creates variations amongst plans and then variations in the organizations, and like our delegated model in California. And we ended up, you know, on the front lines, like we've got 5 different forms that are variations of the same thing, but different interpretations. And instead of working on an improvement project, we then are digging into the operational piece of how do we try to operationalize 5 different consent forms and electronic health record. And at some point, you're just like, it's too hard. This is too much. And so it becomes one of the biggest barriers and places of resistance of integrating behavioral health, which is critical to improving care. And I think, and then the kind of big picture, we are all transitioning to value-based care. And if providers and care teams, one, can't report the quality data that shows that they are serving patients as they are being expected to do, they can't get paid, right? And so then it kind of the circular system where we get stuck. Not to mention they can't perform at the expectations that we're putting out there for them if they're not able to exchange the data that's needed for care coordination. And working with behavioral health specialists to really meet a patient's holistic needs.
No, thank you. And, you know, I think we've started to touch on some of these related to some of the challenges folks are really facing out there in the field when it comes to navigating the real labyrinth of laws we have around privacy and consent to share. And would love to just hear a bit of an elaboration on some of those challenges that folks are facing out there. You know, how organizations like HIEs and others are starting to make sense of those, especially as, you know, Caliim, you know, we're deep in it. We're sharing data across sectors now. You know, would love to hear, maybe starting with you, Shelley, what some of those challenges are and how you've been working with clients to overcome them.
Well, I mean, there are so many laws, and now, you know, double the number of frameworks, right? So we've got data exchange framework and its single data sharing agreement. We've got TEPCA now and the common agreement. We've got policies and procedures. And as if that wasn't enough, we really did have enough when we had just a simple participation agreement based on DRSA and, you know, so on and so forth. So we have so many different bodies of law, contracts that weigh into just the basics of, you know, operating an HIE, getting participants onboarded, getting through the paperwork is difficult. It's just gotten worse, you know. So how do we deal with it? Well, you know, we do still have our basic standard data sharing use cases, and you know, it's gaining alignment and understanding that these agreements really still support the same use cases. We're expanding a little bit now with social services, but it's about gaining and understanding the common language, understanding what those agreements really mean in terms of what we're doing operationally, and then translating that into actual data sharing with partners. So it's been a challenge. It's a challenge now if we can get past the contracting and just kind of refocus on gaining consensus about you know, what we're doing. At the end of the day, we're trying to share data for patient care. So I think we've got some work to do, but it's encouraging.
And Shelley, one follow-up question on that too, because, you know, you mentioned, working with organizations to put these data sharing agreements together, what are there any sort of success factors or tips or tricks you might want to share with organizations that are trying to do that with their data sharing partners, trying to negotiate agreements to share information amongst each other, that account for the DSA, TEFCA, et cetera? Do you have any kind of a thoughts or advice you might want to share with folks?
Oh, really, I'm not really sure, Robbie. The tips and tricks, board buy-in, getting the board to bless the agreements, getting the major institutions, your larger stakeholders, to weigh in on the agreements as you're drafting them. And then, you kind of go through these iterations, and finally you get to an agreement where, lo and behold, you're not getting too many red lines.
Mm-hmm.
So it's an iterative process. I think, fortunately, we're far down the road in terms of these participation agreements. And if the organization is willing to sign on to the data exchange framework, and they know the common agreements, a standard form, the data exchange, single data sharing agreement is a standard form. So there's not going to be a lot of wiggle room, and these are just going to either be used as attachments or referenced in these basic participation agreements. So it's just it's a matter of socializing and gaining adoption by, again, your major stakeholders, and then the rest will follow.
Mm-hmm. Mm-hmm. No, that's helpful. And
Yeah.
Crystal, you mentioned behavioral health as a key area of focus. We heard loud and clear in interviews, and continue to hear about 42 CFR Part 2 as probably one of the most stringent laws when it comes to consent requirements to share information. Can you speak to some of the issues you're running into in your work around behavioral health integration, as they pertain to consent to share and data sharing more generally?
Yes, I mean, and we, put in the context of, we work with practices across the spectrum of payers and populations. So whether it's Medicaid, Medicare, and commercial. And so it becomes a common theme of when we are working with practices to integrate behavioral health, right, that consent becomes a major barrier for them. And for them, it's one of the biggest. And so when they're actually solving for consent, they're often solving for their ability to integrate behavioral health. And so that's where it starts. And on the ground, like I said, we're coming with so many different forms and variations, and the burden that this places on them, and the administrative burden, the HIT burden, right, not to mention the improvement burden, is just so overwhelming. And so, I mean, it's incredible that now we have some guidance on what this should be. I think we're struggling with some very conservative interpretations that are cascaded through organizations. A lot of misperceptions of what that is actually out there results in this very narrow interpretation, and understandably so. You want to be cautious, right? We're trying to be protective of patients and their data here. But it just becomes so overwhelming when you think about a small independent practice that's probably contracted with 5 different health plans of dealing with 5 different forms and trying to do that. And then to introduce different versions of, but if they're a Medicaid patient, they have this. If they're commercial, it just doesn't work, right? And of all the things they have to do that day, are they going to carve out time to try to solve and figure this out? No, because that's a patient that's not coming in for an appointment if they're spending time doing that. And so what you see is this often kind of referring out for behavioral health needs in a way that doesn't kind of circle back and close the loop on care coordination. And that is not what patients need. So I think about the work that we're doing. I'm so excited to see that there is a standard form being piloted, the Ask Me form in Medi-Cal. And I would say on the commercial side, we need that too, right? And from that practice perspective, the serving a whole community, we need a standardized form. And so there was some work to be done, I think, to both pilot that. How do we continue to adapt it and build on it? There were some privacy regulations that had to be waived in order for that to happen. We need that to happen on the commercial side too, so that we have one approach for consent. And then I believe we can come together on that, and that's something we can align around. And I think that's going to help then cascade that to health plans, right? There's no need for variations in this different stuff. So how do we have that common approach? And then we can figure out the common processes by which to make that happen more easily in the system so that it isn't a burden to providers, and they could actually jump in to integrating care.
Mhm. And, you know, I think that's a common issue we've heard too, is that in some ways we're creating possibly more silos when it comes to creating different standard forms for different programs and such. And would love to jump to a question around, you know, what do we do when it comes to legal guidance to stakeholders? And, you know, some lessons learned, I think, particularly from you, Devin, when it comes to recommendations you have from your experience at OCR when it comes to, you know, providing guidance, authoritative guidance, thinking about things like universal forms, and in creating resources like the SHIG. What lessons learned would you like to share?
Well, I guidance, I mean, it sort of feels like a no-brainer, but is incredibly helpful and absolutely essential, particularly for regulated entities, but for the public at large as well, so that people know what's expected. And what tends to happen is you put out guidance like the SHIG, for example, to address a set of common questions, and it helps a lot. And then it generates more questions. People have a slightly different fact scenario that isn't completely addressed by the FAQ that's out there, and they're worried because they're not sure whether they can move forward. And uncertainty is an absolute killer in terms of sort of getting to yes and getting to data exchange. If there's uncertainty is very hard to calculate from a risk tolerance perspective. So there's almost a concomitant obligation on the part of regulators you just can't put a document out there and say, we're done. We've put the guidance out there and we don't need to do anything else with it. And this should be enough for people to work from, because it takes a really long time to get this stuff done and out. But the truth of the matter is that there is a need to sort of constantly curate a document like that, because there are different fact scenarios that will come up. There will be gaps that you didn't think about the first time around that start to reveal themselves as people begin to operationalize something. And you have to get in there and, you know, kind of continuously add. And it takes a lot of work on the part of an agency. And for when agencies don't necessarily have a lot of funding to support the kind of legwork to get that done, it can be a real challenge. You know, the other thing that has to happen is, if you think about efforts to create sort of a singular consent form that will work across multiple different types of data, there may be different regulators involved in that equation. You know, do you get everybody around the table and you get everybody to agree that this form is going to work for the field that I regulate? I will accept this form. I will accept this language in this form. And it's super important for the regulators to then communicate that back out to the public, so you don't have the situation of different risk tolerances, different opinions from different attorneys or compliance people. I think it needs this sentence. I don't think it needs this sentence. Like, it's Shelley's smiling. Like, we've all been through this, right? You know, we all have brains, but we all think slightly differently about this stuff sometimes. And it's going to be really critical that there be kind of widespread consensus, and particularly among, you know, the entities who regulate and where their regulations expect consent, and for them to, you know, be very forthcoming about this works. This, you know, other things could be sufficient too. A lot of times agencies are uncomfortable with saying this is the only way to do it, but it's enough to say this approach is compliant with the rule. This paragraph in this big form, it works for us. It's going to be really important that come along with an effort to create a kind of a consent to share form that is going to cover a wide range of use cases.
No, I appreciate that. I think more authoritative and clear guidance, I think, definitely makes folks feel more comfortable relying on these resources. And Shelley, I also see you smiling. Is there anything you would like to add to Devin's response?
Well, it's kind of funny. Yeah, we did this Ask Me exercise, which is awesome. You know, but when she's saying, you know, we there are, of course, attorneys scrutinizing that form for compliance with different laws, and we're like, well, this isn't quite right, and this and that, you know. So it really kind of didn't pass the test of all of these attorneys, right? But we did learn a lot from the Ask Me form exercise. And, you know, it wasn't really at the end of the day, the form so much as the success in educating the patient about the use of the form, as Crystal was mentioning earlier. It's really about the communication. But, you know, the other thing that, you know, and I know we've had this conversation, Robbie, is, you know, in my perfect world, the state would do something like, you know, we've done in the past with other laws, like the Uniform Probate Code, in getting a standard form adopted and put into legislation, which is, you know, it's something, a document that we can all agree that can be used without, you know, question. And in that form alone, you know, at least one thing is for sure. We can use this form as an authorization form, and it's going to be a valid form, right? So, you know, in my world, it would be awesome if, you know, the state could come up with an authorization form. It doesn't have to be used for all cases, but certainly it would solve, you know, 80% of the cases. So, yeah, so that's my summary. Ask Me was, you know, just exactly what Devin was saying.
Well, I think you're in good company, because I think we heard loud and clear from folks that a form or a piece of a form, a part of a form that, you know, is blessed by the state in some way would definitely make folks feel more comfortable, whether that's in statute or in the DSA or some other place as well. Mohit, I'd love to turn to you to maybe share that the health plan perspective. You know, what is it that you all need when it comes to guidance to be able to share data with your partners, and why? Can you elaborate a little more on why that's important? You know, with
Yeah, absolutely. In fact, I just want to first of all say thank you to the other three panelists, because everything they said I could just repeat, right? Which we're all living through this on a pretty regular basis right now. And I'll just give you a couple of examples specific to how we view CalAIM, which I think is the most transformative effort that any state across the country has undertaken to fully integrate healthcare and move towards population health management. The key to population health management is having the right data available at the point of service to enact the right service pattern and model, right? And thereby ensuring that people are getting the right care in the right setting at the right time. And when you look at the rollout of CalAIM, there's been multiple issues that have arisen over time that we've solved for, as Shelley was saying, on an iterative basis. You know, she's way ahead of the game in San Diego with 211, which, you know, I used to do work with in a previous life as well in that market years and years ago. And I'm really proud of where that ended up and the amazing work that it's able to do. But remember, that was a lot of education. And CalAIM is somewhat similar to that, meaning that there are ancillary providers. There are providers who've never been so, you know, medicalized, if you will, or pulled into a reporting mechanism. There are providers who have so far run on grant funding that are now having to learn basic things like even billing, right? And now we're asking them not only to do those pieces of actually being part of a system of care, we're also asking them to figure out consent. Right. So that's on top of everything else that you're really good at what you do every day. You're really helping women with, let's say, postpartum depression, and you're really good at that. But on the flip side of it, you've now got to manage the data. You've got to learn how to transmit it. You've got to make sure it's secure. You've got to get the right consents. Right. And that's what you're dealing with. So the point about having some standardized approach is not lost on us. Right. Right now, even in the implementation of CalAIM, county level behavioral health data is a concern. I think anybody who's working with 42 CFR Part 2 data understands that this has been a concern for the last several decades, right? Because on the one hand, you have the authorities that you need to get and the consents that you need to get, but then on the other, you have this concept of like every lawyer is going to view it differently. So as a result, you end up with a system where we're having to go into every single county where we work and negotiate MOUs and data sharing agreements and consent, consent management on how that particular county does its work. So if you're looking at 15 counties or 20 counties or 30 counties, depending on who you are and where you do your work, there's going to be levels of sophistication in how they interpret their own rules and the legislation, and then the regulations that come from it. And another example that you would see is like, okay, we now have the justice involved population moving directly into CalAIM, right? And there's this whole idea of in-reach and making sure that people are getting their, again, holistically looked after as they emerge from incarceration. And again, you have to now create consents and everything else with the prison systems and the jail systems, which may never have done this with managed care in the past. So how do their systems now comport with ours? How do we make sure that what Medi-Cal wants, what DHCS as an agency wants, is being replicated or duplicated, or at least covered in how those MOUs and data sharing agreements are done in a new population, right? And when you look at the data sharing agreement overall for the state of California, which, by the way, we were early signers of the DSA, it wasn't easy, again, going through a bunch of lawyers and everything else and compliance internally. People thought I was crazy pushing for that. But if we really want to get to population health management, and if we really want to get into this like digital age of healthcare that we feel we're ready to do, right? We're finally catching up. The data systems are catching up to the promise of care coordination and managed care. What you see now, what you see emerging now is immediate concerns. We've heard this on public calls during DXF, calls run by the agency, where people have even said, we need consent. We need primary user consent for ADT data being shared, right? Now, if ADT data at that level needs a primary consent every time somebody comes in or out of the hospital, without that form, every other quality measure associated with follow-up care cannot occur, simply cannot happen. So if that form isn't checked, I don't know that, I always go back to the life of Linda that Pallav Babaria uses, right? When Linda leaves the hospital, if my care coordinator and her primary care physician, don't know, her OB or, doesn't know that she's been released, how do we do the follow-up care for the next 7 days? Right? So again, consent matters. We must get it right. But I think an equally important part of it is cross-agency coordination, that as we emerge into this massive new playing field of data, right, that's going to actually allow us to improve care and get to population health management as a goal for the state. Without the agencies coordinating, it becomes very, very difficult for individual companies, and especially individual providers or providers who've never been in a medical system before, to actually understand all of this. So the consent form being standardized actually helps move us forward faster, rather than the time for education that it's going to take over the next 2 years.
Ravi, can I jump in with I feel like I want to build on that, because it's not just the patient and their practice, but like when agencies come together to think about a comprehensive solution, whether it's Medi-Cal, whether it's commercial, because these practices and these providers, when they're seeing all patients, and when 40% of your practice is Medi-Cal, which is a significant amount, and most Medi-Cal patients are seen by small and independent providers with mixed panels, they're not going to find a solution for just 40% when it's this hard. They're just going to give up. Right. And then that's actually impeding our ability to achieve the aims and objectives of CalAIM. And so how might we approach that Medi-Cal, while wonderful, I love that they're moving forward, let them set the standard, but consider in that work that you are adapting for a whole system to create the glide path for the commercial side to follow suit. Right. And that is a comprehensive look of serving a community and a population from a practice and a care team's perspective.
And I just point, again, echoing that, I completely agree, Crystal. You're never going to get practices to do 17 things. I mean, they can do one thing, and if it's across all lines of business, then that makes the most sense, right? That's number one. But then you look at even, for example, student behavioral health incentive plan that we rolled out as part of the community and youth behavioral health incentive, sponsored by the state under the bigger rubric of Cal HHS, right? What you're seeing there is if the right data can't be shared, then the counties themselves are unable to draw down the money to actually improve their community and youth behavioral health programming. So again, because the health plan was the conduit for the application, we encountered where we had to actually go in and design specific data agreements that the counties were then comfortable with. And this is state money that's supposed to go to the county, with the health plan basically helping manage the incentive plan. But we can't even operate those without the right consents in place. So I'm just pointing out that we're getting ahead. We want to go where we're going. The question is, how can we remove the impediments to get us there faster?
Well, and I heard there too, as well as I see the chat, a lot about education, education of, it sounds like counties, individuals, thinking about individual needs around language, thinking about different stakeholders and the guidance they need. Any other thoughts from folks? You know, who needs education? What should it be? If we could create an education campaign tomorrow, and on the SHIG and DXF guidance, who needs to be targeted, and what should that look like?
I'll jump in. I'll say everyone.
Yeah, I mean,
I know it's a weird thing to say, but I'm sure, Devin, in your former role, you had to grapple with this issue a lot more than I ever have. So.
Yep. We put guidance out and people didn't know it was there. And we used every channel that we had to let people know it was there. I went out and spoke about it. It surprised the heck out of me when I left government practice and went to build a platform to help patients gather their data. And I thought, I did this guidance like 2 years ago on this. It should now be really easy. Well, it wasn't. And it was like I wrote something in a forest and the tree didn't fall, or it fell, but nobody's, not great metaphor, but you know what I'm talking about? The educational piece to this is absolutely critical. I couldn't agree more with the other panelists as well as the people chatting. If you think that this is just government's role to do, first of all, government will try, but it won't be enough. There is a role for nearly every stakeholder to play, and it will still take a bit of time for all of it to sink in. Mm-hmm. It's people are just used to the thing that they have done, however, not helpful for data exchange, but it's the thing that they've done in their mind. They think it's needed to comply with law, and to reorient all of that, it just takes time, unfortunately. But an all hands on deck kind of an effort will help, because if government absolutely has a role to play, but if you just leave it up to government, there will be significant portions of folks who will never see that education, no matter how hard they try. And it won't necessarily also be translated in a way that particular stakeholder group can understand, whether that's a language issue or just you're speaking regulatory talk, and I don't understand what you're saying. Yeah.
Well, and I'll reflect beyond the education, right? I think it's then how to use it. So one, I would say most people don't know it's there. So, we come up with it. I was like, well, by the way, there is now a resource, but then it's about kind of that, I think about the support, right? It's the hand in hand of, here's the piece of it you need of this, how big a document, right? And here's how can you adapt it. And I feel like, to your point, there are tables where we could start doing that, and knowing that they are doing it in alignment with others, I think will help accelerate action towards that. We're all willing to jump in and do this. And so how do we think about a coordinated way to not just share it, but help them actually put it to use? I'll put my hand up. I would love to be doing that. We have a behavioral health integration improvement collaborative, 9 provider organizations touching 500,000 Californians right now, right? And so we're trying to digest it and better understand of our advising that we do to help them tailor inside each of these organizations. But that's just 9 provider organizations, right? And just 500,000 Californians. And so how might we do some of that kind of deeper beyond just education, but the next step of, and here's how to use it.
Mm-hmm.
Awesome. Any other thoughts, Shelley or Mohit, on that?
Well, I mean, the
just say,
operationalization is key. Sorry,
Yeah.
Shelley, go ahead. But
Oh, I was going to say, in San Diego, it's worked really well to have these, work groups. We have a number of work groups and training that occurs when participants are onboarded, particularly for 211 CIE. And so there's a whole training program that the organizations go through, and how data is shared, how it's protected, and those are really helpful. And it's what's been successful in gaining consensus and moving the community forward to share information. So, and many of those work groups include county agencies, health plans, the large hospital systems, small providers. So it runs a gambit who's in those work groups. So again, it's about taking these guidance documents and the use cases and running through them with your community. So it can happen at the individual operational organizational level, but again, as Crystal's mentioning, this could occur on a statewide. I mean, we could take the SHIG and take a topic and have work groups, hosted by BluePath and have a question answer session on all of these nuances that the FAQs just don't get to.
Mhm.
And there are many. I mean, I've struggled with questions about, well, it didn't deal with this particular situation, and I've been left, kind of scratching my head, and many times, I hate to admit that when my clients aren't listening, but
Yeah, no, it happens, and then you have to work
Yeah.
your way through it, but you don't have the kind of certainty that having something that came a little bit closer to addressing your particular situation would have given you.
Mhm. Right.
And-
The other thing I wanted
Yeah,
to
sorry.
mention is, we have this great opportunity. I don't know if we're really talking about it enough, but with CalAIM and the NPRM that we're waiting for with the HIPAA modifications,
Mhm.
will really change what we are currently thinking we need when it comes to consent or authorizations, right?
Mhm.
If we get greater clarification on what is care coordination and case management, and what does data sharing mean under that, and a clear statement that authorizations are not needed, then we're going to solve a lot of problems, right? Because then we're only trying to figure out when an authorization is needed for that the 5% of the time for those outlier use cases, maybe that involves extremely sensitive information. So guidance from the state, movement towards aligning, CalAIM and HIPAA, and greater focus on care coordination and case management. What that really means cross-sector would be so beneficial right now.
Well, and I would mention too the forthcoming updates to Part 2 as well, which Congress mandated to SAMHSA to make updates in the 21st Century Cures Act, which I think, while not totally completely aligned with HIPAA, I think it's a big step forward in terms of trying to harmonize those laws, even just in the terms used, like the legalese in both of those statutes, and how you can navigate them, as well as how you provide consent as an individual as well. I would also mention, oh, sorry, Mohit.
Oh, no, I was just saying that we've got to think about the operationalization of this
Mhm.
very directly. And, with the data exchange framework, just as an example, we have to create the ability to have people ping us for data, right? And let's say a provider office pings us for data because they have a patient coming in 2 days from now. Our system pings every other system that we're connected to in the data exchange framework, brings that data together, delivers the packet. If at that point that provider does not come into our system with a consent token for a particular type of data, we can't share that data. You see what I'm getting at? So as a result, the consent has to be actually adjoined to the data request from a workflow perspective. Otherwise, that data cannot be released. In fact, my lawyers won't let us release it. So as a
Although you got
result,
it in the first place, so that's interesting. Maybe you had a consent for it to be sent to you, but not further down the pipe.
But if
Yeah.
it's the wrong provider type, they can't
Ah.
get the data. So remember, data must be shared for the right purpose with the right person at the right time, right? So as a result, we're going through this internal workflow piece right now where we're ready. I feel I shouldn't say that out loud because the lawyers will get mad, but we're on track to be compliant with the DXF by January 31st, 2024, which is a huge lift for us. Okay, we've devoted the resources and we're right there. But these are the last questions that are now popping up. How do we build the provider portal, the intake of the ping, and what consent needs to be built into it or not? So clarity here could not only mean functional improvement in how the data flows, clarity here could also mean significant savings in terms of the builds that multiple entities will have to do to be compliant. So it's something to consider. In I know people who live in the data world say there's no such thing as real time because there isn't, right, from a physics perspective. But if you look at it, if you want real time data interchange, the consent packet must flow with the data, and we haven't gotten there yet.
Well, a good plug, Mohit, for our next two webinars where we'll be digging into those topics more from like the standards and technology perspective too, around, how we make this happen. And I'll put in a plug too, for organizations interested in pulling down funds, there's the TA Marketplace. If you're in CalAIM, that funding can be used to help your organization develop a strategy. There's DXF funds. Sounds too like we might have an idea too around the need for more funding when it comes to, education around guidance, beyond the education grants this year, as well as perhaps too around implementation with the DXF and CalAIM as well. Also, I would love to invite folks to please drop questions in the Q&A. I see one question here. I don't understand why individual California counties can have different policies. It's a major challenge for California and other states. Maybe I think your question could be what could be done to resolve that? Any ideas around, maybe powers the state has to help resolve that issue, or maybe other tactics that you've seen work on the ground?
I'll jump in. I think one of the things DHCS is doing now, which I think we've all looked forward to in the context of CalAIM, is that they are trying to standardize some of the MOU function through templating, right? I don't know that it's going to solve for everything. But again, multi-agency coordinated guidance in this area would be a big step forward, specifically for those entities that have lived in different legal constructs, whether it's counties, whether it's prison systems, whether it's others. Going back to my original point on CalAIM, multi-agency agencies that have jurisdiction over different parts, creating conjoined guidance on this issue would go a long way towards releasing data for appropriate uses.
Yeah, and I see the comment in the chat too. We're solving this complex challenge 58 times. So templates, state solutions, definitely it sounds like would help. One other question came in that chat too around, patients, historically marginalized communities that may have faced mistreatment, may feel like their data is not being, utilized for, desirable purposes, or, breaches are happening. What I have some thoughts here, but what would folks say to those folks who may be, skeptical of maybe, relaxing consent laws, for data sharing purposes, and what benefits might some changes in policy hold?
Well, one thing I would say is that some of the things that cause people to get nervous about data sharing are frankly not that well fixed by consent. That's like basically saying, crappy system that doesn't protect your data, your only choice is not to have your data shared or not through your consent, right? As opposed to, let's fix also some of the things that make people nervous about data sharing in the first place. Let's make sure that the onus for protecting data and doing good with it and not using it for discriminatory purposes remains on the data holders themselves, as opposed to shifting all that burden to the individual to say, oh, are you going to be in or out of this crappy system? Having said that, we've been talking all along, we do have consent laws that do allow for patients to have some choices about whether particularly certain types of data are going to be shared. How we're going to operationalize that is going to be a huge challenge. That data is often, sometimes it's, with individual providers. I don't want this provider's data shared, but everything else is okay. That's frankly easier to operationalize than none of my mental health data, which, by the way, happens to be commingled in all sorts of other data that's hard to necessarily pull out. That's a bigger challenge, but it's all a big challenge to operationalize.
It is, and parallel to those challenges of operational, it's such a great opportunity to bring the care team into this dialogue. I go back to, this is the engagement tool, and so I think it's a dialogue that a provider and other care team members can have with a patient and their family. And I think addressing a lot of the questions that do exist, and rightfully so, right, and working through that together and being able to choose which parts, not which part, but also we need to train and educate the care teams on how they can respectfully take that dialogue on, because right now they don't feel prepared, right? And they're overwhelmed. And so it happens in a way that perpetuates the mistrust. And so I think there's a different way that we can overcome it. And that's not a tremendous amount of resources. I'm sure I know that there are wonderful best practices out there. And so that's just kind of finding those bright spots, right? And we integrate that into other improvement work that we're doing in the system.
Yeah. Well, I know we only have a couple minutes left, and would love to turn to each of you. If you could share one key takeaway, one piece of advice for stakeholders who are connecting for better health of the state as we take this journey towards improving consent to share to really reach data sharing. What would you like to leave behind? And Mohit, I'd like to turn to you first.
Right. So I think as we look at consent laws, we also want to look at what's working and what's not working. One of the things that I've come to realize over the years is that, some simple things like in this day and age, being able to text your member and tell them that they have something available to them is often considered marketing, right? But the point is, if you're trying to coordinate care, if you're trying to get people to self-identify into race, ethnicity, and language categories, a lot of people work off their phones. And a lot of things that we're being asked to do statewide almost require us to be in better touch with our members on a pretty consistent basis, whether CalAIM related or care coordination related. So one of the critical things that I would say is, like, if things aren't working, like asking us to mail out a form to get text consent, and we know what mail rate returns look like in the state of California for healthcare purposes. Maybe we move forward and get some of those rules realigned, or have a single gateway where people provide that consent. So.
Excellent. Crystal, any final thoughts?
I just want to reflect of how far we come that we're having this conversation. This is kind of amazing to me to think about the work that we started on that. And there's so much here. And so while there's a lot that needs to be, we need to continue to work through it, there is actually a lot here for us to take steps. And how might we do that? This isn't an area where anyone needs to compete over consent, right? So we are all willing to jump in and sit at the table together. And to Mohit's point, like, why are we solving it so many different ways, spending in different ways, right? That takes money out of the system that's supposed to be helping patients and care teams. And so how might we leverage some of the tables that already exist and the willingness of everyone? Like, we're motivated to solve this. Like, I hope that energy came through today. And I find that everywhere. And so how do we kind of run with the momentum we have? The SHIG is here. There is a standardized consent that has been piloted. I mean, that's amazing, right? I don't think a few years ago I would have anticipated that. And let's keep it going. And we need some partnership with the state to keep it going, to support their efforts, and then to be able to cascade that through the system.
I love it. And look, folks are agreeing with you in the chat too. So I think definitely more work to come with that. And Shelley.
Well, I think, again, like Crystal was saying, this is a great conversation. It's great that we're all coming to the table and talking about consent and data sharing, more importantly. And as I mentioned earlier, I'd like to see more consensus around the definition of terms, more consensus around the forms and contracts that we're using. I'd like to see things get condensed. You know, we don't need hundreds of pages of contract forms. We don't need authorization forms that go on for pages either. What we need is a standard understanding of what we're trying to accomplish and the use cases that we're trying to support and how we're going to do it. So if we can get some buy-in from, you know, the state agencies, county agencies, again, large healthcare systems, all speaking the same language, kind of understanding that while I may say, you know, provider of healthcare or covered entity, you know, we use these fancy terms and everybody's got their own definition. We actually mean the same thing, right? So let's kind of get past the attorneys and get to the workforce and train accordingly and start sharing information finally.
Awesome.
Yeah.
I love it. And Devin, take us home. Any thoughts?
We have a need through the data sharing framework and the CalAIM projects to have sort of like a statewide solution for this, right? But we always have the problem of trying to boil this great big ocean that we live right next to all at once. And it definitely is going to take a lot more time. Take the pilot that just happened and scale it one step farther and do it quick and show some success. And then go a little bit farther after that. Get a couple of counties aligned that are next to each other. Get it done there for certain types of data. Oh, it worked. Let's keep going. Let's keep going. Build incrementally. Don't try to find the one thing that's going to work. It'll take us forever.
I love it. I love it. Start small, start with key first use cases. And well, I really appreciate all of you and your thoughts and your insights and joining us today. Really great conversation and lots of action items we've been jotting down too. So definitely more work ahead. Thank you to all of our attendees today. We'll be sharing out the recording shortly. And really wish everyone a great rest of your day and many thanks to our panelists too. Take care, everyone. Thank you.
Thank you.
Bye, everybody.